Esteemed members, good evening. Thank you for joining us today in this webinar. If you can hear me, just kindly send a message on the chat and let us know which branch of PSK you're joining us from. If you can hear me, kindly send a message on the chat. All right, I see there's a message coming in. Thank you so much. Thank you, Dr. John, Dr. Poptani, Dr. Amsalu, Dr. Dennis. Thank you so much for your confirmation. So as we wait for our other colleagues to join, there's a test that is currently running on the screen. So as we wait for our colleagues, there's a poll that is currently on your screen. Kindly just fill it in. Thank you for confirming your branches. As we wait for our colleagues to join in, kindly just take part in the poll that is currently on the screen. Once you're done with the poll, kindly go to the PPB portal and make sure you subscribe to this event. The name of the event is Antimicrobial Use in Community Pharmacies. Go to the PPB portal and search for the keyword antimicrobial, and you'll be able to see this event labeled Antimicrobial Use in Community Pharmacies. Kindly subscribe early so that you can get your CPD points on time. For those who are joining, we have a poll that is running. Kindly fill up the poll as we wait for other colleagues to join. For those who are joining, we currently have a poll that is running. Kindly take part in the poll and give your responses. Once you're done, go to the PPB portal and search for this event. Use the keyword antimicrobial, and you should be able to find this event on the PPB portal. Remember, the earlier you subscribe, the earlier you get your CPD points. So kindly ensure you subscribe early. For those who've joined, we're just subscribing on the PPB portal for this event, as well as doing the poll. So kindly subscribe on the PPB portal, use the keyword antimicrobial, and also take part in the poll that is currently on your screen. All right, thank you. So I see we are now at 400 members who've joined us. So we're just going to get started. So first, I'd like to thank you all for joining this webinar. And this webinar today is on antimicrobial use in community pharmacies. And our partner for today is USAID MTAPS program. So we have two speakers who are experts in this area, and they'll be speaking to us on this topic. And I'd like to just do an introduction of our first speaker, Dr. Nkatha Gitonga, who is a healthcare professional in the public health field, specializing in health system strengthening and service development. By profession, she's a clinical pharmacist with experience working within the public health sector and in clinical practice. Currently, she's the Senior Technical Advisor for the USAID-funded Medicines, Technologies, and Pharmaceutical Services, MTAPS program, that is being managed by Management Sciences for Health, MSH. She provides technical advisory and project management for the global health security agenda on antimicrobial resistance in Kenya, working at national, county, and healthcare facility levels. Our second speaker is Dr. Karim Wanga, who is a pharmacist by training, and he graduated with a Masters of Pharmacy in Pharmacoepidemiology and Pharmacovigilance from the University of Nairobi. Recently, he completed a fellowship program in antimicrobial resistance from London School of Hygiene and Tropical Medicine. He has worked with PPB for over 10 years across several regulatory functions, which include regulatory inspections, pharmacovigilance, and post-marketing surveillance. Currently, he is the Chief Principal Regulatory Officer at the Pharmacy and Poisons Board in the Department of Product Safety. He has a special interest in drug utilization studies and medicines regulatory science. So just before they start, once again, to remind you that you'll be muted during the entire course of this session. So if you have any questions, kindly use the Q&A tab so that we'll be able to track the questions, and then they'll be addressed by the presenters at the end of the session. Once again, if you've not subscribed for this event, kindly do so. Go to the PPB portal and use the keyword antimicrobial, and you'll be able to find this event. Also, this session is being recorded and it will be made available to the PSK YouTube page. And just on the agenda for today, my name is Hezron Munyakin. I was doing the opening remarks. We'll have our speakers presenting. Then thereafter, we'll have a Q&A. Then some closing remarks from Dr. Ndinda Kusu from MSH, USAID MTAPS. And then finally, we'll have the closing remarks. So at this point, I'd like to welcome our first speaker, Dr. Nkatha. Karibu.
Thank you so much, Dr. Hezron. Kindly confirm that you can see my screen and you can hear me.
Yes, I can see and I can hear you clearly. Thank you.
Great. So thank you so much for all those who are attending this session. As mentioned, this will be a discussion around antimicrobial use in community pharmacies that will be co-presented by myself and also Dr. Karim. So I would just wish to begin with some information around the program that we're working in that has sponsored this webinar, and that's the Medicines, Technologies, and Pharmaceutical Services program. And the goal of this program is really to enable lower and middle income countries to strengthen their pharmaceutical systems, to ensure sustainable access to and appropriate use of effective, quality assured, and affordable essential medicines and medicine-related pharmaceutical services. So in essence, some of the work that we have been doing, or the scope rather, for the MTAB's Kenya activities have been around containment of antimicrobial resistance. So we work at the level of multisectoral coordination for AMR at the national level and also in the county. And we also support enhancing infection prevention and control and optimizing the use of antimicrobials through antimicrobial stewardship. Our scope is of at the national level, 4 counties, which is Kisumu, Nyeri, Murang'a, and Kilifi, 20 facilities for IPC and 24 for AMS within those counties. We've also supported IGAD EAC medicines regulatory harmonization work. So that's around regulatory system strengthening, regional and cross-border pharmacovigilance agenda, and local manufacturing work. We've also had some work around COVID-19, IPC, and also vaccine deployment. And we've also had some work around vaccine manufacturing capacity building for the country. We've also supported some National Pharmaceutical Services Unit survey. So this is the broad work that we're doing, but what has brought us here today is the work really that we do around antimicrobial resistance. So as mentioned, we have multisectoral coordination work. So that's the One Health work around AMR, and that's at national and county level. IPC work that we also support implementation of CPD and relicensure linked in-service IPC training, the same for AMS training. But AMS training also includes support around pre-service training. So I'll give an overview around antimicrobial resistance. So as we know, I'm sure this is not something that is of new to us, but we can have a quick refresher. So how does antibiotic resistance work? In general, we know that the utilization of resistance happens naturally first. There's the mechanism that happens naturally, but also the exposure or the overuse and excessive use of antimicrobials agents can also lead to bacteria or microbes becoming resistant or bypassing the mechanisms of those antimicrobial agents and therefore rendering them resistant. So basically you have some few antimicrobials. When you do use the antibiotics or the other antimicrobials, they kill the bacteria, but they also kill our good bacteria. And this gives an environment for resistant bacteria to grow and take over. And we also know now that some bacteria can actually can transfer resistance to other bacteria, causing more of a problem. So really, when we look at how we've gotten to this stage, antibiotics in particular were miracle drug that have become really a victim of their own success. We've had penicillin that was in the petri dishes of Alexander Fleming's study, to how much antibiotics were used post the Second World War in treating soldiers. So there was a vast use around then, and they were really a miracle drug because people were not dying, or soldiers were not dying from, amputated legs or surgery due to their injuries because of an infection. But then these antibiotics found their way into the farms of Boston, and they were being used for growth promotion, which is now really has been disputed as not really benefiting or more than harming the growth or the productivity of farms. Then we had the pharmaceutical golden era, and this is when, healthcare became very accessible to a lot of people. So there was a lot of surge in the prescribing of antibiotics. So that has brought us to now, which is really a post-antibiotic era, with some antibiotics not being effective at all to treating infections. But Alexander Fleming actually predicted antibiotic resistance, and he really said the thoughtless person playing with penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin-resistant organism. And I think as pharmacists, this is something that we really need to remember, and it might be a quote that we really have to replay when we're reviewing prescriptions and making recommendations, that we really think about the appropriateness of these antimicrobials in general. So the evolution of antimicrobial resistance is quite alarming. So since the 1940s, the time frame between when an antibiotic is introduced or developed to the time when resistant occurs has shortened at an alarming rate. So on the right, you can see an image, and basically the lines that you see from the left to the right in the different colors show when the antibiotic, on the left when the antibiotic was introduced, and on the right when antibiotic resistance was identified. And you can see that line is becoming straighter and straighter, which means that resistance is occurring way quicker than it was a while ago. So how big is this problem? So estimates in the 2019 study by Lancet showed that 1.27 million deaths were attributable to AMR. And this, if you look at this graph, I've plotted some figures from Lancet as well for the other disease states, and you can see that it's higher than the deaths associated to malaria and HIV, and slightly lower than that for TB. So really, it's a global issue. And in that same study, it was projected that sub-Saharan Africa would be attributing to most of those deaths by 2050. So factors that contribute to AMR, we know the use of antimicrobials when they are not needed, that is no infection present, can contribute. Errors as well in the use of antimicrobials, so inappropriate antimicrobial choice to the causative bug, but also inappropriate dose or inappropriate duration. Not completing treatment courses, overuse in livestock and fish farming, and lack of hygiene and also poor sanitation. We're also seeing a decline in how we're conducting our infection prevention and control practices post-COVID. There's been a reversal in those strict practices, so that can also contribute, or that does contribute to the spread of AMR. Also, the lack of new antibiotics being developed. So we know the pipeline is slim. We know that it takes a long time, between 15 to 20 years, for an antibiotic to be developed, and no new agents. And by new agents, I mean agents with unique and new mechanisms of actions have been developed. A lot of them that are coming out are modifications to existing molecules. So what does this mean for us? If we allow AMR to continue, what would happen? So 1 out of 9 people who got skin infections before antibiotics died from things as simple as a scrape or an insect bite. 3 out of 10 people who contracted pneumonia died. 8 ear infections caused deafness, and sore throats were followed by heart failure. So really, before antibiotics, simple infections which are currently easy to treat will become difficult and impossible to treat. Infections which were once eradicated will reemerge, and superbugs will continue to develop and increase. Therefore, modern medicine will be threatened. So what's the picture in Kenya? There's a National Antimicrobial Resistance Surveillance Report that was released in 2022. It's been recently released, a 2023 version during last week's WOW activities. And it revealed a growing burden of AMR in priority pathogens, consistent with patterns that were observed in 2021 and those reported in other regions in the world. We've seen high percentages of resistance to second and third generation cephalosporins in E. coli and Klebsiella pneumonia, increasing fluoroquinolone resistance to E. coli and carbapenem resistance to Acinetobacter, which really represents a call to action. Also, the 69% of the data was from inpatient departments that included critical care units. This, coupled with the fact that most of the priority pathogens are implicated in healthcare-associated infections, could imply infection prevention control practices have lapsed, thus promoting the spread of the pathogens. What's interesting in this statement is that 69% of these resistant bugs or these resistant patterns are being seen in inpatient departments, but the question is how many of these patients have been having multiple courses of antibiotics before they are admitted into hospital. So AMR containment in Kenya. So we know it's a public threat, and it's a threat in Kenya, just like in most low and middle income countries. So Kenya adopted the May 2015 agenda of the 16th World Health Assembly, calling on member states to develop national action plans to combat AMR. So this led to the development and launch of the national AMR policy and national action plan in 2017, which was aligned to the global action plan on AMR, and it incorporated 5 strategic objectives. And it was actually based from 2 situation analyses that were conducted in 2011 and 2016. So it provided a coherent policy framework and priority actions for containing AMR in Kenya. So this national action plan and its associated monitoring and evaluation framework was revised in 2023 for the next 5-year implementation period. So this is just to show you the strategic objectives within the NAP AMR for the period 2023 to 2027. And we have 6 strategic objectives now. Strategic objective 1 was added, which was to strengthen governance and coordination mechanisms for AMR containment. Strategic objective 2 is still around awareness, education, communication, and training around AMR to increase understanding. 3 is around strengthening knowledge and evidence based on AMR through surveillance and research. Strategic objective 4 is around infection prevention and control. 5 is optimize the use of antimicrobials in human and animal and plant health. So this is really where we sit under. And strategic objective 6, also where we sit, is to support sustainable investment that takes into account of the needs of Kenya. So this is research around new medicines, diagnostics, vaccines, and other interventions. So we, as pharmacists, we really sit in all strategic objectives, but, you know, with a great focus around generating awareness, which is 2 and 5, optimizing use, and also under research. So the coordination mechanism, and I won't spend long with this, this is all in the National Action Plan, but we have the National Antimicrobial Stewardship Interagency Committee, and they are the national governing AMR coordination mechanism for AMR, and it has four active technical working groups. At the county, we have a similar mirror image of this committee, as known as the County Antimicrobial Stewardship Interagency Committee, and they're really responsible for AMR implementation at the county level, including resource mobilization. At this stage, I think we believe we have 15 CASICs, because we know that Nairobi has recently inaugurated their CASIC, and MTAB supports 4 of these CASICs, as mentioned earlier. So here are some of the milestones that have been made by the country on AMR implementation. So I've mentioned some of them, so I won't go through a lot, but we had a situation analysis that led to the National Action Plan and policy being developed. We've had AMR surveillance strategies being developed, and the reports that you have seen. The KEML 2019, which is crucial because it has access, watch, and reserve categorization of antibiotics. We had the National Stewardship Guidelines being developed in 2021, and also the M&E framework for the NAP AMR. We've also been submitting data to GLASS, and Dr. Karim may be able to mention that. And recently, last week, the country launched the revised National Action Plan and M&E framework, and also earlier, or in October, the launch of the KEML 2023 and the first National Medicines Formulary, both incorporating aware categorization. So I'll briefly just go through the experiences of and opportunities of antimicrobial stewardship programs in community pharmacies. And this was really done as a questionnaire to one of the community pharmacies we support in the program. And through the questionnaire that we employed to the 2 community pharmacies we support, we were able to get some findings and some commonalities between the 2 in terms of some aspects. So I'll begin with the barriers associated with implementing AMS programs in community pharmacy. So at the prescribing level, it was found that identification of who the prescriber was an issue. Training of clinics and nurses in the community, there's some sort of lack of forum for this kind of engagement. To be able to ensure the validity of a prescription was difficult, and also that sometimes there were prescriptions that came to the chemist for injectable IV antibiotics or injectable antibiotics. At the patient level, it was questionable who is administering intravenous antibiotics to these patients. Currently, there was no pathway for observing adverse drug reactions for injections provided out of the hospital. So obviously, we know we need to observe a patient for a minimum of 30 minutes to assess whether there's an adverse drug reaction, and that we don't know if that's happening in the community. Regulation, so there's substandard community pharmacy services that have been noted, where some pharmacies are providing injections of antibiotics, some may not have licenses, some may not have qualification. And something interesting was around these briefcase pharmacies. So in the counties that we work, we found that there's some malpractice happening where people are walking around with medicines in briefcases and selling. So that's something that is also maybe contributing to AMR, but also limiting the interventions we can make. Standardization of care pathways. So we have multiple cadres of staff involved in patient care. So this over handling of a patient leads to patients, seeking information and then becoming expert patients. So they want to make their own decision, including when they should be taking antibiotics. And patients also have health-seeking behavior. And I know we all know that they would take pharmaceuticals. They can also at the same time take herbal medicines or traditional medicines. And this is duplication of care, but also it can cause adverse drug reactions and heightened side effects. Staff capacity. So one of these was also a limitation where it was reported that there's semi-skilled staff in community pharmacies that may not have the technical knowledge to make such interventions on prescriptions, and availability of information, education, and communication material around, AMR, AMS, IPC. So they felt that it was not currently available. Obviously, after signposting to some of them, they were able to locate them. But however, we don't feel like this is widespread knowledge on where they can get this IC material. So some of the interventions that have been made by these 2 community pharmacies is at the prescriber level, they've been able to quality check the prescriptions, ensuring that institution is recorded, prescriber is recorded, and they've also been starting to build relationships with the clinician, and so that they're able to identify relationships between clinician and patients, encouraging that there's continuity of care, that you see the same, if as much as you can, you see the same clinician and the patient goes to the same pharmacy, so that there's some sort of continuity of care. At a patient level, they've been able to build rapport with patients, clinicians, customers, which has allowed for education to be provided, because now people have more time. When you build rapport, they have more time for you to speak to them about these critical issues. And they're not allowing over-the-counter sales of antimicrobial. So how they did that was creation of control mechanisms for OTC sales, educating staff on that, and policy development. In terms of education, they reported that implementation is definitely tied to the current knowledge of staff. So there's ongoing training on assessing good quality medicines as well, but also prescriptions. On a product level, medicines that are prescription only are not dispensed unless there's a the pharmacy in charge is there. Also, the pharmacovigilance for low quality medicines is ongoing, and reporting for non-registered medications. So really, what are the opportunities for pharmacies starting antimicrobial stewardship programs? We can actually create a community of practice to promote standardized care pathways. If you all speak the same message, then it's easier to change behavior of prescribers, but also patients. So training should include community prescribers and focus on appropriate prescribing. What are the minimum standards of prescriptions, etc. Level of care to be offered by different accredited pharmacies. So we really advocating for, some sort of way to accredit pharmacies so that, it builds trust among the public and also, supports these pharmacies that are going the extra mile to establish such programs. Also, we're really encouraging development of policy and guidelines, as this enables induction programs to happen when new staff come in and they're inducted into appropriate way of dispensing antimicrobials, etc. Public awareness, so really education of the public as an initiative of community pharmacies. We're hoping to see community pharmacies really come out with the public awareness around AMR, because they are the, most patient-focused, like in terms of touch time with patients. Community pharmacies really have that time with patients. We're also looking to see a lot of, sharing of experiences from community pharmacies through platforms such as this one, PSK platform, hearing from community pharmacies, what are the challenges, what are the opportunities, what are the interventions that have been made. Surveillance of antimicrobial consumption and use. This is something that we really need the buy-in from community pharmacies, but also we need a system in a way that there can be notification of potential outbreaks to the Ministry of Health that are identified at the community level. Also, and I think I've mentioned this, but community pharmacies to link to patients' primary doctors and also for patient records. So to be able to assess prescriptions, you really need enough information as possible. So being able to link, systems so that your patients can easily transfer some certain information to yourself. So we're also looking at community pharmacies to develop IC material around AMR, AMS, and safe use of medicines, but also IPC. And for them to, support PPB with regulation recommendations. So there's certain things that need to be changed or improved, then we need to hear the voice of the ones who do this work. Also, there's been advocating for consultation rooms in pharmacies and focus group discussions with clinicians in the community. So what are the benefits of actually doing AMS programs in community pharmacies? It's a way of marketing the pharmacy through publications, story sharing, and through AMS interventions to the public. By doing this work, you are ensuring quality care to patients. So you envision that you'd have repeat patients based on, building the trust and providing quality care and services. You'd also be able to attract high quality staff, students, interns, who know that there's more, there's more to offer in the pharmacy. And also it's a potential to, be recognized as a center of excellence within community pharmacies if that eventually comes, and you'd be contributing to the fight against AMR. So I'll hand over to Dr. Karim to give us an overview around the antimicrobials handling practices in community pharmacies setting in Kenya, which was a pilot study done by the Pharmacy and Poisons Board in collaboration with the World Health Organization. Over to you, Dr. Karim.
Thank you, Dr. Nkatha, for that good presentation. So just move to the next slide. My colleague has already made that background presentation on the problem, the magnitude of the problem of AMR globally, but also locally and even in our communities. But just to maybe emphasize that recent studies have shown there's an increase in AMR due to misuse, overuse, and unauthorized access of antimicrobials over the counter. And also Dr. Nkatha has very well elaborated on the National Action Plan and the strategic objectives around National Action Plan, and really our area, which is optimal use of antimicrobials. And I think that has been really well said. Next slide. So for this study, it was a pilot study to try and see how we can implement a good distribution practice inspection tool. Those of you who are in community pharmacies, you might be interacting with the PPB inspectors who come around to carry out good distribution practice, GDP inspections. But we noted internally within PPB that this inspection tool did not have any parameters that were focused on antimicrobial resistance. So it's an attempt or aim to include some questions within that inspection checklist or aid memo to see whether those questions can actually aid us to focus a little more on AMR parameters. And so we aim to pilot that checklist or tool. And of course, the problem statement is that one of the key drivers of AMR is the illegal sale and dispensing of antimicrobials over the counter, especially prescription-only antimicrobials. We have quite a number of our pharmacies which are dispensing them without prescriptions. And we know this is one of the drivers that is leading to AMR. In terms of specific objectives, was to pilot the tool, but as well as identify some AMR questions that can be integrated on our online good distribution practice inspection tool for future inspections, just in terms of enforcement, but also to support community pharmacies in terms of stewardship. Next. So it was a cross-section survey. We used both descriptive qualitative methods. We had a checklist that was developed by experts from Pharmacy and Poisons Board. Also to note that we collaborated with NEMA, that is a National Environment Management Authority. Environment now is a key partner in the tripartite for AMR. And of course, the other one is animal health and county governments as well. We focused on 2 counties, Nairobi and Mombasa, and we used a preset criteria to determine the 2 counties. The list of facilities that we visited were randomly selected from the list of registered outlets by the Pharmacy and Poisons Board. So we targeted 100, and the activity was conducted between the 5th and 6th of June of 2023. Next. So in terms of results, just trying to the screen. We also checked whether these outlets had an authorized person, and this is important because if the authorized person or a qualified person is present, then we know that in terms of stewardship already there is a step forward. So we just wanted to check whether an authorized person in that pharmacy, but we found that majority of the pharmacies had an authorized person. However, we had a few which did not have an authorized person. So 92.78 had authorized persons, the rest did not have. Next. Next slide. In terms of record keeping and documentation, we checked whether these outlets actually kept an updated register, and that was very interesting. Majority of the outlets did not keep a register. They did not have, sorry, just go back. Okay, yeah, majority did not have an updated antibiotic register. Only 11 had a register that was updated. In terms of records of supplies, specific to antimicrobial supply to the facilities, most of them had records of the invoices, delivery notes, and other records of supply. So that was well done. In terms of filing of the prescriptions, also we had a significant number that about 43 of them had actually filed their prescriptions. So they had a file that had actual prescriptions filed. But we also had quite a number, actually majority did not have a file with the prescriptions. And yet there were other records that were showing that antibiotics had been dispensed. Stock control systems, majority had a stock control system in place, whether there were bin cards, stock control cards, and other electronic systems, while we still had a significant number that did not have any system in place. And then in terms of documentation of interventions, so many interventions happening over the counter in terms of review of the prescriptions, calling of the prescribers to change the prescription, and other interventions that were being done, even change of dosage or treatment durations and so on. But however, these interventions were not documented. There was testimony that they were being done, but we could not see any evidences of documentation. Next. We looked also at another area of awareness and education for the practitioners in those facilities. So we asked whether there was anyone who could identify themselves as a champion of antimicrobial stewardship. And so a majority of the facilities reported that they did not have anyone who was a champion for antimicrobial stewardship. While we have few who, based on their response, they said they have someone and they could actually name that person, that is the person who is responsible for stewardship, antimicrobial stewardship. Reference materials, only about 16 out of 84 out of 100 had reference materials available, antimicrobial resistant, any material, whether it is just general information targeted to the public or any other proper guidelines. And I think Dr. Nkata has mentioned about national antimicrobial stewardship guidelines. Most of those facilities did not know the existence of those guidelines, neither did they have those guidelines in their facilities. In terms of IEC materials targeted to the public, this is where I think there was least performing. Almost none of the facilities had any IEC materials displayed, while we actually saw other IEC materials in other areas, especially around COVID and other things, but we not see anything on antimicrobial stewardship or AMR. Training, this is very interesting, that quite majority of the respondents actually say they have been trained. They have been trained on AMR, either in webinars or workshops or other seminars, but that was not reflecting so much on the practice. Next. In terms of control measures to prevent errors, whether they are dispensing errors or other errors in terms of prevention of medication errors, we found that majority of facilities do not have any mechanisms to check or even prevent errors that are likely to occur. So the double checks were not being done. Mostly it was just one person who was transcribing and also dispensing the prescriptions. They do not have any computerized systems really to be able to do to check on any medication errors or drug-drug interactions and others. In terms of prescription validity checks, most of the respondents said they actually do check the validity of a prescription to see whether it meets the minimum requirements of a prescription, but also had quite a significant number who did not carry out any checks on validity of prescriptions. Next. So storage, we all know that storage is very critical in terms of maintaining quality of our medicines. Storage conditions are critical. And one of the counties we visited in Mombasa, and you all know about the conditions in terms of humidity and temperatures in Mombasa. So we found that majority of the outlets actually were not controlling the storage conditions in terms of ambient storage conditions for most of the medicines, which is most of the time is below 30 degrees Celsius. Majority of them did not have, the air condition facilities for their premises. And that means that if we have, those high temperatures and maybe humidity, then we are not very sure about how the products will behave or perform. Cold chain, also those who had fridges, they were not monitoring the temperatures in the fridges, and they were not also keeping a chart of the temperature. So they just had a fridge most of the time, which was not a pharmaceutical fridge, and this fridge did not have a fridge thermometer, neither were they keeping a chart. In terms of access of control areas, majority of them had access, had control access to the dispensing area and where the control medicines, or rather prescription only medicines, were kept. Next slide. Client feedback mechanisms. We had majority of the respondents did not have any procedure for handling feedback from clients, or even complaints, whether it was on issue of an adverse drug reaction, or poor quality medical products, or any other feedback from the patient. They don't have a proper procedure that was documented. And also these feedback records were not kept of any intervention based on customer feedback or client feedback or patient feedback. And this is related to pharmacovigilance. Also, we realized, and that's in terms of percentages, we realized that we noted that most of them did not have a focal person responsible for pharmacovigilance in the pharmacies. Of course, we understand that most of those pharmacies only had one person who is a qualified person. But even where there were more than one person who was dispensing or working in those pharmacies, they did not have a designated person as a focal person for pharmacovigilance activities. Next slide. So we also just stretched a bit and looked at infection prevention control and waste management. We know now that some of our pharmacies are actually providing some of the tests using rapid diagnostic tests, and they generate some clinical waste. So we wanted to check how do they manage these waste, which is a potential, a source of, could be potential source of infections. So hand hygiene, very impressive. Most of them had some hand hygiene facilities, running water and a sink where able to, do hand washing. Color-coded pedal bins. Majority did not have color-coded pedal bins. Only a few had those color-coded pedal bins. In terms of procedures for cleaning and hygiene,
Hello, Dr. Karim?
I think we've lost him.
Okay. So
Yeah.
I think
Okay, meanwhile, colleagues, as we wait for Dr. Karim to join us back.
can you hear me?
Yes, we can hear you. Karibu.
Okay, I don't know what happened with my laptop, but yes. So in terms of procedures for cleaning and hygiene, majority did not have any SOP. Potable water, most facilities had some form of potable water, and then disposal of pharmaceutical waste. We were just asking for responses on how they dispose pharmaceutical waste, and we realized that quite a number of them just have people from municipality or others who come around to collect the waste, and then there was no proper segregation of the waste as per the IPC guidelines. Next. So I think that in terms of the discussion, I've already gone through this, so I'll just go straight to just next slide. So in conclusion, most practitioners at the community pharmacies lacked awareness on AMR. The sale and dispensing of antimicrobial agents over the counter of that prescription was rampant. There was poor record keeping and ineffective stock control. The revised checklist will be integrated into the existing online GDP inspection tool to be able to focus a little more on AMR parameters during the GDP inspections. And then there's need for collaboration with partners and stakeholders to improve the handling, dispensing, and use of antimicrobials in community pharmacies. Next slide. So in terms of recommendations, continued education and training. We need to reinforce training programs, both pre-service and in-service, and sensitization for pharmacy professionals in community pharmacies on antimicrobial stewardship. This one I think has been mentioned already by Dr. Nkantha. Then in terms of documentation and record keeping, emphasize the importance of accurate and detailed documentation of antimicrobial prescriptions, treatment plans, and patient outcomes. We know at pharmacy level, there's a bit of intervention that are being done by the pharmacist, but I think the documentation was not really up to date. Also, we aim to develop and standardize antimicrobial registers to be able to facilitate easy record keeping, reporting, and audit trail, especially at the point of use. And this will help us all to generate consumption data, as we expected actually to measure consumption of our antimicrobials at different levels. And then awareness to the practitioners to develop and implement SOPs for infection prevention and control measures. Next. Regular audits and monitoring. We aim and hope to continue conducting these audits for antimicrobial usage and also prescribing practices, dispensing and also prescribing practices to ensure ongoing compliance with guidelines and identify areas for improvement. Enforce compliance with Pharmacy and Poison Act as read with the rules and guidelines on AMR. Now there's the whole issue of records keeping and being able to submit data on consumption. And I think this has been anchored on the Pharmacy and Poison rules. Then scale up PMS and enforcement to operationally implement the relevant PPB guidelines. Practitioners should be sensitized and trained on pharmacovigilance reporting and client feedback mechanisms. I know we have done a lot of trainings on pharmacovigilance and reporting as well, but I think this needs to be strengthened as well. And then review PPB rules to mainstream regulation of antimicrobials by scheduling them under expanded categories of prescription only, restricted medicine, and specialist prescription medicines. So there is already there's a list of let me call them schedules. There's already a schedule. There are schedules that have been developed on different categories of medicines, but these schedules can only be gazetted, I think, when there's an amendment in the law. So once that issue of the legal issue is addressed, those schedules will be published, and there'll be clear categories in terms of prescription only, specialist prescription, and even restricted medicines. And we try to align as much as possible with the AWARE categorization. Next. Public awareness and campaigns. We need to collaborate with public health authorities to raise awareness among the public about the appropriate use of antimicrobials and consequences of AMR, and also importance of infection prevention control. Develop and provide IEC materials to practitioners to promote widespread information sharing and communication to clients and public at large. So IEC materials were missing. I think is an area we need also to focus on in terms of dissemination. Next. Governance and coordination. We are already collaborating with MOH, but we need to collaborate further in terms of policy frameworks, rules and guidelines relevant to AMR. We also need to strengthen interagency collaboration and mobilization of resources to be able to, support the measures in containment of AMR and liaise with other health regulatory agencies, especially, the Kenya Medical Practitioners Council and other agencies to be able to standardize practices. Regulation, again, it cannot be overemphasized, and it can only, if it's done only in animal health, human health and not in animal health, then it will be counterproductive. So it has to be coordinated efforts across human and animal health. And then integrate AMR parameters within the PPB, GDP and online inspection tool. We're already working on these, and hopefully soon they'll start deploying that tool that has a bit of AMR parameters. Next. So these are some of the photos of prescriptions that we saw, and also records that were being kept at the pharmacies. Next. This is one of our inspectors with one of the practitioners. Next. Yeah, so stock control system, computerized. Next. And this is the meeting where we were writing the report. Next. Yeah, so thank you so much. Over to you, Chair, the session.
All right, thank you so much, Dr. Karim and Dr. Nkatha, for that presentation. So I see we've received a couple of questions. Maybe I'll just start with the first one, which is on, the first question is from Dr. Eric, who asks, how does bacteria develop resistance when antimicrobials are used in absence of infection? So maybe anyone who can respond among the two of you.
All right. Thanks for that question. So I think we need to remember that we have bacteria, or what we term as quote unquote good bacteria, in our bodies. So when we do use antimicrobials where there's no infection, that bacteria can also learn the mechanism of the antibiotic and become resistant. And in my first slide, remember I said that bacteria can actually transfer resistance to another microbe. So that's how it can happen. But you also, when you treat with antimicrobials, you can actually wipe out your good gut flora, which then makes you more susceptible to infections. And there's also been studies around the using antimicrobials and how they impact our white cell count through some interaction with the protein chains. So it actually causes more harm than good, in more than just developing resistance, but obviously side effects, also some modifications in the body where antimicrobials are in the body but there's no infection, so they can actually cause more harm than good.
All right, thanks for that. Dr. Karim, do you have any comments on that as well?
No, I think Dr. Nkatha has responded.
All right, thank you. So there's another question from Dr. Mwebia, who says, what measures can be taken, especially on antimicrobial use during pandemics? For example, during COVID-19, where at the beginning of the pandemic, where there was no proper guidelines on antimicrobial use, and in the community or hospitals, there was an overuse of azithromycin and the coamoxiclav. So what measures can be taken during such times?
All right, I think I can add, and then maybe Dr. Karim from his position can maybe chime in. But I think we need to give ourselves grace with what happened during COVID. As he's rightly mentioned, or the participant has rightly said, there was lack of guidance. So a lot of people were, just prescribing. But that's why we say antimicrobial stewardship is really it really needs pharmacists' involvement, because we knew it was a virus. We knew antimicrobials don't have no value in treating viral infections. So I think a lot of it is the multidisciplinary approach in deciding this treatment pathways for new or emerging infections or pandemics. So in hospitals, we're really advocating for medicines and therapeutic committees, because they're the ones that set the precedent on how medicines are used in the facility. And we've had some successes in some of the hospitals that had strong MTCs during that time, because guidance came quickly. Even if there wasn't any guidance nationally, the hospital, through the MDT, which is the multidisciplinary team, were able to give some sort of guidance on the use. So that would be an area around that, is to have, multidisciplinary teams making these decisions in small scale, in lower scale, but also nationally, and not waiting for international guidelines, but also making decisions and spreading that information. Dr. Karim?
Yeah, thank you. I think the other approach would be creating awareness as well. I know public did not have much information, and there was panic. Of course, people were trying everything to either prevent or try and manage self-medication. So I think that communication coming from the experts, coming from associations, for example, PSK, KMA, other associations who are, the professionals, giving advice to the public on the issues of self-medication, but also providing guidance on what needs to be done in terms of prevention of infection, transmission, but also in terms of treatment that is required in terms when it comes to pandemics. So I think there was a lot of effort at national level. There was constant communication that was coming from the ministry and all that. But I believe we would have done more, especially coming from professional associations, to take the forefront with our pool of expertise, really to advise both government, but also to advise the public on what needs to be done in terms of the interventions, in terms of infection prevention and control, and in terms of those who are already, contracted the virus or bacteria, what should they do instead of going for self-medication. So I think those will be some of the approaches that optimize and help reduce abuse of antimicrobials during pandemics. Over.
All right, thank you. We have another question from Dr. Eric, who asks, what is being done to control the use of antimicrobials by the veterinarians, and who's the responsible person to run vet antimicrobials?
Okay, so that's an interesting one. Our veterinary colleagues for animal health, we have a regulatory authority called Veterinary Medicines Directorate, VMD. It's responsible for regulation of veterinary medicine. Remember, this used to be under PPB, but it moved to VMD. And so they also have some efforts that they are doing in terms of creating awareness among those practitioners or the people handling veterinary medicines in terms of stewardship, and also to ensure that they can be able to track consumption. But I will not want to speak for our veterinary colleagues. We are collaborating under One Health, and I know they necessarily do not have all the capacity. Maybe PPB, since we are older, we have some capacities. We have our people on the ground, the inspectors moving around, and we have some systems we have established. But we are working together, and I think we have reached out to ensure that we're moving together, since we are very well aware if we do so much in human health and we don't do as much in animal health, then most likely it will be counterproductive. So regulation of imports into the country, restriction of some of those reserve antimicrobials, as well as stewardship or accountability at dispensing points. I think that will be key, and we keep on sharing some of these with our colleagues as well from our veterinary sector or animal sector. Maybe Dr. Nkatha has something to add.
Yes, thanks, Dr. Karim. I think you've elaborated exactly how I would have said, but it's just to also note that a lot of the advocacy or the awareness is being generated. So as he's mentioned, a lot of the AMR containment, or all the AMR containment efforts in the country are under the One Health approach. So that's bringing in the Ministry of Agriculture, Livestock and Development, the mining, which is where fisheries sit, environment and human health. So they're working together, and through this One Health approach, and I think I've seen even Dr. Oscar here, which is a mirrored image in the county. A lot of the advocacy has come out from the agricultural side to educate farmers, but also educate paravets and agrovets on the appropriate use of antimicrobials. So as Dr. Karim said, I think human health, we're a step ahead. We've been starting this work, way ahead, but the agriculture team have come strong. And I think a lot of it is around awareness. And as they pick up on the regulation and really quantifying consumption around the animal health side. Thanks, Enoch.
All right, thank you for that feedback. There's a question from Dr. Ibrahim Malim to Dr. Karim. Most of the private pharmacies have automated programs or systems. Can we have the antibiotic registers as an integrated tool to these automated programs, or have an automated one?
Yes, definitely yes. Not all pharmacies, but quite a number of pharmacies now have automated their systems and processes. And I think there's a minimum data point or data fields that you need to have in your register, antibiotic register. So already I know in public sector through the Ministry of Health, they have distributed some of those registers. And we are discussing with my colleague, Dr. Tanui, how can we have a template that can be now used by private sector? Because I know in public sector, I think already some registers have even been printed and distributed. So I think once we are able to identify those data points, it's a matter of configuring those ones within your electronic systems, and you can use those ones to be able to keep the records. So it doesn't have to be a manual system. And also maybe just some work that we're also working with MTAPs, we're doing MTAPs, is to be able to digitize some forms, a form that can be used to collect data on actual consumption. So the quantities in terms of, milligrams of different molecules that you have consumed over a period of time. And this will help us to do the analysis into the consumption metrics and that we can actually use to compare county to county or region to region based on disease prevalence patterns, population and size and all that. And also even at country level, help us to compare ourselves with other countries that have almost similar population dynamics and also size. So we are working on the forms, and those ones will be digitized. There'll be electronic forms, and we'll do a pilot, and we hope that they can be integrated within your electronic systems as well, and you can push data to us on consumption of antimicrobials over periods of time. Thank you.
All right, thank you. Seeing Dr. Nkatha has dropped off, but there's another question that is still addressed to PPB, and I think it'd be best to answer. So there's a question from Dr. Wata, who's asking if there are any steps that PPB is taking to ensure community pharmacies don't sell antibiotics without prescriptions. And maybe as you just respond to that, you can also talk on the matter of poor quality and falsified medicines with a focus on antibiotics.
Okay, two loaded questions. Actually, the most important questions. In terms of stewardship, because really it is about antimicrobial stewardship at community pharmacies. PPB, of course, we have a role in terms of enforcement, of what the law provides for and what the new rules provide for. However, it still remains the real duty of our professionals, those who are practicing in the community pharmacies, to ensure that if an antimicrobial is a prescription only medicine or antimicrobial, then it should only be dispensed on prescription. So it's a difficult one. We are grappling with it. We are struggling with it. It's not just us, even other people also around the world are also struggling with it. But it will take all of us, both regulatory input or regulators' intervention, as well as on self-regulation by the profession, to ensure that there's the discipline to only do the right thing, which is dispense on prescription. There is a few measures that we are doing, like I mentioned, integrating some of these parameters within the inspection tool, the GDP inspection tool, to be able to apply that tool during inspections and then get feedback and try to apply some enforcement, but also categorization based on the schedules. We believe once these schedules can be enforced or published, and then we carry out the sensitization and awareness with the profession to ensure they're aware about the schedules, even the public. Hopefully that can also bring clarity in terms of what should be given over the counter, what is pharmacy only, what is pharmacist only, what is over the counter, what is general sales, and what is specialist prescription. So if those schedules come into place, and we, as I had said, we already have the schedules, but there's something that needs to be done in the law to ensure that now that can be gazetted, and those ones I think will make it will clarify further, because it's also aligned with the aware categorization in terms of access watch and reserve antimicrobials. So we have to work together. It's not an easy thing. It's not going to happen. We're not going to finish it tomorrow or today, but we have to walk the steps and walk the journey together in terms of creating public awareness, but also talking among ourselves as professionals, as community of practice, to say that really we need to look ourselves in the eye and say we have to do the right thing and preserve these precious commodities by only giving to those who need them. And those who need them are the ones who have a prescription, because then they have gone through the proper diagnosis with maybe a laboratory, diagnosis, and they truly need those antibiotics. And those who have viral infections and other issues, then they should not get antibacterials. I mean, they should be, given other interventions. So I think it is a conversation that we must have, as much as the regulator will make some interventions, but I think professionals themselves also have to take the step forward. Over.
Right, thank you, Dr. Karim. Just for our colleagues, we also have a post tests, which I'm just going to launch now as we continue with the Q&A.
Dr. Hezron, I forgot about the substandard and falsified.
Oh yes, yeah. Maybe you could just say something.
So we continuously monitor our market for any quality issues of our products, including antimicrobials, and we've had a few incidents of falsified products. Maybe you've seen in the media. Whenever we come across, detect something that is falsified in our market, we issue a rapid alert to reach as many people as possible so that we protect, health and safety of the public. But also continuously we receive feedback from yourselves, who are the users of these products, to tell us this suspected substandard product, and we carry out investigations with the market authorization holders as well as manufacturers to just check what will be, carry out the root cause investigation analysis to know where the problem is, especially for substandard products. In terms of the surveys that we have done previously or in the recent past, let's say in the recent 2 to 3 years, and the test parameters we are focused on, whether it's assay, dissolution, uniformity of weight, and others, I can confidently say that the compliance has been good. Compliance has been good, at least for what we have gone out to sample and test. Compliance has been very good. whether they are antibacterials, whether they are antivirals, or whether they are, mainly are focused on antivirals and antibacterials. The compliance has been really good. So we are confident that quality is good. We still have reports from yourselves on substandard products, which we have investigated to be able to know what the issue is and work with manufacturers in terms of the corrective and preventive actions. And so we are really keen to ensure that what we have on the market meets the specifications, because we want to say if it's AMR, then it's truly AMR, and not because of quality or content in the content of the active ingredient in the product. And that's why we have been intentional to include antimicrobials within the scope of the products that we continuously sample and check quality. Over to you, Chair.
All right, thank you, Doc. Just moving on to the next question. We'll have 2 more questions, then we finalize. So there's a question on what's being done at the prescriber level in regards to aware guidelines to reduce overprescribing or treating and irrational prescribing of antibiotics. So maybe Dr. Nkatha, you could give something on that.
Thank you for that question. So what's being advocated for on the prescriber level, I think he's already answered some of it, is actually, pushing for aware categorization. What does that mean? Is that we have restrictions for who prescribes some of the reserve and watch category antibiotics. By restricting that, then we're hoping that that will lead to a reduction in their utilization, because now we're having steps, put in place prior to a reserve or a watch category medicine being dispensed. So pharmacists have to actually confirm and ascertain that the procedures have been put in place before they dispense a reserve or a watch category antibiotic. So we know there's a number of facilities that have implemented the prior authorization of watch and reserve antibiotics, and some of them are MTAPS facilities that are represented here. And so that means that there's clinician buy-in for that. But other clinician interventions that have been made is obviously advocacy around them, and also development of local treatment guidelines. We've seen that being very effective, where consultants are making a decision on what we're using to treat. But pharmacy also plays a custodian or a steward role in safeguarding how these reserve and watch category antibiotics are utilized. Thanks, Anova.
Right, thank you. There's a question here on prescribing. So in the event one realizes that an individual was wrongly prescribed with antibiotics with no infection, do we abruptly stop or allow them to continue the full dose?
Okay, so in an absence of an infection, then we stop antibiotics. That's the message. So if there's a confirmed absence of infection, then we stop the antibiotics. They do not complete the course of the antibiotic if there's confirmed absence of an infection. Thanks, Anova.
All right, thank you. So maybe just the last one as we complete. So Dr. Wanjiru Kigadi says there was an initiative to have a county pharmacovigilance focal person in every county. Are there plans for PPB to partner with the county governments to enforce this and establish this role permanently? Maybe
good question. Actually, this will be the second time now I'm hearing that comment. I just came from Taita Taveta yesterday, and I got that feedback as well. We have to partner, and I know there are regions in the country where the regional inspectors, the county coordinators for PPB are closely working with the county pharmacist, as well as the county pharmacovigilance focal points in terms of regulation in terms of audits of those healthcare facilities and pharmaceutical outlets. So there is an opportunity, I think, for us to collaborate, and it does not have to be an MOU. I believe there's goodwill, since pharmacies facilities are in counties, and we have the county structures. Then there's no reason why our PPB structure, governance structures should not collaborate with the county governance structures that exist. I always say personally, when I used to work in the Coast region as a regional inspector, I used to have very cordial working relationships with the people working at the counties, but also even the healthcare facilities, because really they are the eyes on the ground. So please, let's go ahead and collaborate where possible. But in terms of pharmacovigilance focal points, the rules that were published, pharmacovigilance and post-market surveillance rules, have provided that each county should have nominated a county pharmacovigilance focal person. So already that is provided within the law, and I know most counties have already operationalized that. They have appointed the individuals, and we already have held a meeting with all the focal points from all the counties to start establishing that framework in terms of how we collaborate. And even within the rules, they also provide for the collaboration between the two levels, that is PPB and also county governments, in areas of pharmacovigilance and post-market surveillance. So the policy framework is already there, it's established. I think it's a matter of how we operationalize and create a structured framework on the collaboration. But it's there already established in the law. Thank you.
All right, thank you so much. Maybe Dr. Nkatha, do you have any additions on that?
Thanks. No, I don't. I think he's comprehensively answered that question. But I think before I dropped off, briefly, we saw a question around vaccination and how that promotes AMS. So I just wanted to really say that. So I know vaccination has been known as a method of preventing or infection prevention and control measure, but its value in antimicrobial stewardship is very underrated. So obviously, if you get immunity or if you develop immunity against some of these infections, then it means that the opportunities for you utilizing or overusing antibiotics is reduced. Therefore, people who are vaccinated then are less likely to develop antimicrobial resistance. So actually, one of the strategies of antimicrobial stewardship is to advocate that all patients are fully vaccinated and up to date with their vaccinations. Thanks, Anova.
All right, thank you, Doc. So maybe I just wanted to share the poll results from the previous tests and this last one. So I don't know if you'd like to just briefly go through the responses and maybe give the right answers. So this was the first test. We had 392 responses.
Okay. So I can go through this. The first question is, the AMR rates in Kenya show a low percentage of resistance to second and third generation cephalosporins. It is false. So majority have answered correctly. So of the current AMR rates present in the country, what percentage of data represents inpatients? That's 69%. So majority answered that correctly. Number 3 was, which one of the following does not contribute to the spread of AMR? And correctly answered was using antibiotics when diagnosed with a bacterial infection. So obviously, poor infection prevention and control practices contributes. Also using over-the-counter medicines for cold and flus, and misuse and overuse of antimicrobial. So the correct answer was using antibiotics when you have a clear diagnosis of a bacterial infection. Number 4 was, the overuse of antimicrobials in livestock and fish farming contributes to the development of AMR. So majority have answered correctly. It is true. There's a large use of antimicrobials in livestock and fish farming, and it is contributing to AMR. As we've said, the health of one sector impacts the health of another. So if our animals and our fish have resistant microbes in them, they can be transferred to us and cause an issue within human health as well, and the environment. Thanks, and over.
Yeah, so this is just the poll that is currently running. We have so far, I think 170 responses, and I think there's an improvement on the responses as well, especially on question 1 and 2. All right, thank you for that. So at this point, I'd just like to invite you again to just give your parting shot before I welcome Dr. Ndinda Kusu. So maybe we could start with Dr. Karim, then Dr. Nkatha.
Thank you. I'm happy to note that the participation is actually very high, 423 participants. It shows the keen interest that our colleagues, all of us, have in this topic, which is a very important topic for all of us. And sometimes when we sit back, we think that AMR will be an issue for someone else. But until maybe a close relative or one of us actually gets into this issue of AMR, and they have to struggle with this issue, then that's when it hits hard. So as professionals, we have taken an oath to be able to protect the safety and health of the public. And one of the ways to do that is actually through stewardship. We handle these very precious commodities. They're very powerful. They save lives. And we have been given that opportunity by God to be able to really protect them. So let's just do exactly that and preserve these very precious commodities that save lives on a daily basis. So I think there's no one else who has that chance. We produce them, we manufacture them, we distribute them, we stock them, we provide information on how they should be used, and that is very powerful. And when you have a powerful tool, I think the only thing you can do with that tool is to be very responsible. And that's what I call upon all of us, to be very responsible with how we use our antimicrobials. Otherwise, thank you for the opportunity.
All right, thank you so much, Dr. Karim. Dr. Nkatha?
Yes, thank you so much to everyone who has joined and stayed with us till the end. It shows the interest in this area, and we just really want to continue working with community pharmacies, but all pharmacists in a whole, because as Dr. Karima said, pharmacists are involved in every single process in the development and the use of antimicrobials, but all other medicines as well. And we're really trusted professions out there in the public. So it's our responsibility. And as I said, we remember the quote that Alexander Fleming said all those years ago, that it's actually, the thoughtless person who misuses the penicillin is responsible for the death. And I'm paraphrasing for the people who'd succumb to AMR. It's an economical issue because it does impact our economics. It does impact the health of even our loved ones. So I know there are many people here who've seen some of those AST results or the antimicrobial susceptibility test results that show resistance to everything. And in that situation, what then happens? It means that you're putting this patient on palliative care because there is no treatment you can offer that will take away this infection, and they'll eventually succumb. So it's a real issue. We're seeing it in Kenya. It's no longer an outside issue. It's here with us. So I'm really employing us as pharmacists to take on this work the way we have with so many other programs. But really the AMR space really needs the dedication of pharmacists. So thank you so much for your attention.
All right, thank you so much, Dr. Nkatha, for those closing remarks. At this point, I'd like to welcome Dr. Ndinda Kusu, who's the country director for the USAID MTOPS. Dr. Kusu, if you can hear me.
Yes, thank you, Dr. Munyakin, and thank you really to you for excellent moderation, and thanks to Dr. Karim Wanga and Dr. Katha Gitonga for the excellent presentation. I also really want to thank the participants for staying on. At one point, we were actually 631, and now we are about 400 or so, meaning that this topic is very dear to all of us. So on behalf of, MSH and also the MTAPS program, again, I also want to thank you, Dr. Munyakin and the PSK leadership for making it possible for us to have these presentations, these conversations. But then also on another point, allow me to speak and comment as a pharmacist that really AMR is real. And it's caused, by misuse, overuse, or other. And we need to be very aware and also take our place to contain antimicrobial resistance. It's actually killing more people, as you saw, more than HIV and malaria. And as pharmacists, we have many roles that we can play. And just to quote a few as part of our parting shots is that based on the National Action Plan and across the different objectives, we can really support a number of those objectives. Whether we are working in hospitals or community pharmacies, we also have a role really to promote a prudent use of antimicrobials. We can also bring ourselves to the table so that we are not on the agenda at the policy levels, at national level, at county level, and also in other places, including the research space, whether it's research institutions. But then again, in our different spaces, we can also continue to advocate. We can do this in academia. We can do this, in many other areas to ensure that we promote containment of AMR. So with those many words, I just want to say thank you. And we look forward as MTAPS to continue collaborating with you, PSK, and also the participants on the call in strengthening pharmaceutical systems and containing AMR among other areas. Thanks, and back to you, Dr.
All right, thank you so much, Dr. Kusu. So at this point, I'd just like to thank everyone for joining this session. For our panelists, Dr. Nkatha, Dr. Karim, thank you so much for the wonderful insights you've shared with us. And we're looking forward to having more sessions with you. And for the MTAPS program as well, asanteni sana for your support. So just before we end, I'd like to remind you again, kindly ensure you subscribe to this event on the PPB portal. Once you subscribe early, that's when we'll be able to share your CPDs early. And then just to remind you on a few upcoming activities, this Thursday, we'll be having a webinar with L'Oreal Dermatology, which will be focused on pharmacists in dermatological care. So kindly mark your calendars for that activity. Then we currently have a communication on call for articles for the Farm Exchange. So for those who have not shared the articles yet, kindly do so. There's an upcoming activity for the Nyanza branch, which will be happening on 2nd December. It's a symposium that will be happening at Sarova Imperial Hotel in Kisumu. So for the members in Nyanza branch and the surrounding areas, you're welcome to attend that event. Just contact the branch chair, Dr. Irene, and she'll be able to direct you. The other announcement is on the comprehensive pharmacy skills workshop that had been scheduled to happen at USIU. Right now, it's kindly note the change of venue. It's going to be happening at Aga Khan Pavilion, 5th Parklands. So we have some few more slots. So for those who've not registered, kindly do so. Then finally, on 9th of December, we'll be having an activity in partnership with other stakeholders where we'll be doing a tree planting, then a nature walk and a Zumba session. So for those who are able to, kindly attend Saturday, 9th December. Thank you so much and have a great evening.
Thank you and bye.
Thank you, everyone. Bye.
Thank you. Good night.